The passing of time. It's hardly noticed during a busy day. But the value of each moment comes sharply into focus when something goes wrong, when seconds can mean the difference between a smooth recovery and the development of complications. Consider the potential risks of intravenous therapy. A flow control clamp inadvertently opened. A needle dislodged from its vein. Inflammation of the cannulated vein. Prompt detection and management of these problems, and many others associated with IV therapy, are vital to the patient's comfort and safety. Taking the time to look for problems helps to assure the patient's well-being and recovery. In this program, we'll review the steps involved in preparing for venipuncture and venipuncture techniques. Then we'll discuss how to assess for problems and complications of IV therapy and what interventions to use when complications occur.
Laura, did you see the new order for an IV from Mrs. Scott?
Yes, I'm checking it right now.
I think that Dr. Hugo's planning surgery in a couple of days, so we're starting the antibiotics now. The admixture just came up from the pharmacy.
Okay, does she know about the surgery?
Yes, he's talked about it with her.
The decisions and steps involved in preparing for venipuncture are just as important as those during the actual procedure. And being prepared with the right equipment saves time and helps put the patient more at ease. To select the equipment, you must know the purpose of the infusion, the duration of therapy, and the type of medication or fluid to be infused. Other things you'll want to consider when choosing an intravascular cannula are the following: the patient and her condition. For example, is she likely to be restless? Is she obese? And the location and condition of usable veins. The superficial veins and their branches are usually used for peripheral IV therapy. The naturally splinted metacarpal veins should be used first when IV therapy is expected to last for 3 or more days. The cephalic vein, located along the radial aspect of the forearm and its branches, are also ideal sites. The accessory cephalic vein is another good choice. It is found along the radial surface of the forearm and extends to the dorsal venous network. The basilic vein is located along the ulnar surface of the forearm. Venipuncture using this vein is more difficult, but it is naturally splinted and thus usable. Try to select the most distal vein when starting IV therapy, because each time venipuncture is repeated, you must select a site proximal to the previous insertion site. Next, collect all the equipment and supplies. In many hospitals, kits containing povidone iodine solution, an alcohol prep pad, povidone iodine ointment, a drape, a tourniquet, gauze sponges, tape, an adhesive bandage, and an ID label are available. Since sterile equipment helps to prevent problems, carefully check the packaging to be sure it has not been damaged or opened. And check the expiration date to be sure it hasn't passed. Repeat these steps for each packaged item you will use. If you've decided to use a transparent IV dressing rather than a 2x2 gauze pad, get that now also. Many nurses prefer using this type of dressing because it is impenetrable to water and bacteria, but is permeable to oxygen and allows moisture vapor to escape. It also lets you inspect the infusion site without removing the dressing. Select the IV solution that you'll need. Usually, the type of solution and the volume are determined by the doctor's order, but it's still your responsibility to double-check the validity of the order with a pharmacist or a drug reference book, especially if medications will be added to the solution. The administration set you decide to use is determined by the purpose of the infusion and whether or not a mechanical flow control device will be necessary. Finally, select the intravascular cannula. For peripheral IV therapy, a wingtip needle or an over-the-needle catheter, or ONC, is preferred. The wingtip needle is usually preferred because it's easier to insert and has a lower risk of infection than other cannulas. It should be used when short-term therapy is anticipated. The over-the-needle catheter is more comfortable for the patient and it causes less trauma to the vein. It also has a lower risk of infiltration and thrombus formation. Consider the gauge and length of the cannula. Gauge specifies the diameter of the cannula, and length refers to the length of the needle or catheter. When making your decision, consider the venipuncture method, vein depth, the amount of subcutaneous tissue over the vein, the viscosity of the solution, the rate of infusion, and the size of the vein being cannulated. When you selected all the equipment, you may wish to prepare the administration set before going to the patient's room. To do this, remove the protective cover from the solution bag. Look for any cloudiness, precipitate, discoloration, or signs of leakage. Then, hang the bag on the IV pole. Next, open the administration set. Remember to follow aseptic technique as you handle the IV tubing. Close the clamp, then remove the protective cover from both the administration port and the tubing spike. Hold the spike without contaminating it and firmly push it into the administration port. To prime the tubing, begin by squeezing and releasing the drip chamber until it is half full. Remove the protective cap from the luer lock adapter. Open the clamp, let the solution flow until the back check valve injection port and air eliminating filter are filled. Partially close the clamp and invert the back check valve. Tap it briskly to remove all the air. Do this to the injection port and the filter as well. Allow the filter to hang and finish priming the tubing. Then close the clamp and replace the protective cap. Or you can connect the wingtip needle to the luer lock adapter and prime it also. Now you're ready to perform venipuncture. As you do, use the following precautions and techniques to help minimize unnecessary trauma to the vein and insertion site during venipuncture. Apply the tourniquet tightly enough to palpably distend the vein without interrupting arterial flow. Have the patient assist by making a fist several times or gently stroke the skin over the intended puncture site. Use caution if you must lightly tap the vein a few times to distend it. Follow aseptic technique throughout the procedure to help prevent contamination of the venipuncture site. Current recommendations include wearing gloves during venipuncture and whenever you touch the infusion site. To perform venipuncture with a wingtip needle using the indirect approach, hold the needle with the bevel facing upward and firmly squeeze the wings together. Pull the skin taut and downward over the insertion site to stabilize the vein. Then hold the needle at a 10 to 20 degree angle to the vein to avoid penetrating the vein's opposite wall. Enter the skin distal to the point where the vein is visible. Advance it through the subcutaneous tissue. You may feel some resistance or note a slight pop as the needle enters the vein. Use a gentle lifting pressure as you advance the needle into the vein. Now let's review venipuncture using the direct approach using an over-the-needle catheter or ONC. Grasp the ONC by the flashback chamber located just behind the needle hub. Hold the ONC at a 30-degree angle to the skin with the needle bevel facing upward. Using one motion, pierce the skin and vessel wall. Advance the ONC gently into the vessel. Watch for a backflow of blood into the hub. When the catheter tip is positioned properly, secure the catheter with tape, and withdraw the needle as recommended by the manufacturer. Connect the IV tubing to the needle hub and start the infusion. Check the site for signs of swelling or irritation. Document the venipuncture procedure. Include in the notes a complete description of the infusion site to provide baseline data for comparison during future assessments. Now let's discuss how to recognize and deal with flow rate problems, infusion site complications, and selected systemic complications of IV therapy. Flow rate problems can be caused by many factors and can have potentially serious consequences for the patient. For example, an increased infusion rate may place the patient at risk of developing circulatory overload, pulmonary edema, or speed shock. A decreased infusion rate may deprive the patient of needed fluids or medications. Now let's look at how to assess flow rate problems.
How are you doing, Mrs. Smith?
Well, okay, I guess, but is this thing supposed to hurt?
Well, what seems to be the problem?
Well, ever since the medicine started, it's been hurting.
Okay, well, let me check it out here.
To assess for flow rate problems, check the infusion rate frequently. Recommended schedules vary from twice every 15 minutes to once every 30 to 60 minutes. Let the patient's condition be your guide. Each time you check the IV, observe the fluid level in the solution container. An infusion that's allowed to run dry may cause a clot to form at the tip of the intravascular cannula. Also, depending on the type of administration set being used, there may be a risk of air being introduced into the blood circulation. If less than 100 milliliters of solution are left in the container, plan to replace the solution container, convert the cannula to a heparin lock, or discontinue therapy. Next, count the number of drops being delivered per minute. Compare this rate with the prescribed rate. Readjust the rate when necessary. If a mechanical flow control device is being used, check it frequently, since you cannot completely rely on the device. Remember that mechanically controlled infusions may continue, even if the flow is obstructed through the intravascular cannula. Continue the assessment even if the drip rate is correct. Inspect the full length of tubing, making sure it's not disconnected. Straighten any kinks which could slow or stop the infusion. Raise any portion of the tubing that may be below the infusion site. Also check the inline or final filter on the administration set if present. To check the filter, detach the tubing from the cannula hub. If the filter is clogged, solution will not flow. Changing the filter according to hospital policy will prevent this problem. Note the height of the solution container in relation to the patient's position. It should be about 3 feet or 1 meter from the infusion site. If this distance is greater, the flow rate increases. If the distance is less, the flow rate decreases. Examining the infusion site carefully will also help you assess flow rate. Inspect the skin over the vein proximal to the infusion site. Note any discoloration, such as a reddened streak along the vein, which may indicate infection or thrombophlebitis. Gently lift one side of the dressing covering the infusion site. Examine the area for any local changes that could alter the infusion rate, such as infiltration. Also, check the position of the intravascular cannula. It should be in line with the vein. If it isn't, the cannula bevel may be lodged against the vessel wall. To correct this problem, withdraw the cannula slightly or place a folded 2x2 gauze pad over or under the hub to change the cannula's angle. Finally, check the cannula for patency. To do this, kink the tubing a few inches from the hub and look for a blood return. Even when the cannula is well positioned and no other problems have developed, you may not see a blood return. This may happen if a small gauge cannula is being used, if the patient's veins are small, or if the patient's venous pressure is low. When possible, confirm patency by lowering the solution container to a level lower than the patient's heart and look for a blood return. If there isn't any, a clot may have formed at the tip of the cannula. If you suspect a clot, do not irrigate the cannula, because this could release an embolus into the blood circulation. Also, do not aspirate the cannula, as this could traumatize the vein. Instead, discontinue the infusion and restart it at a different site. To restart an infusion, select a site on the opposite arm when possible. If the same arm must be used, select a site proximal to the initial site. If your assessment indicates the flow rate is too slow and there is no evidence of blockage, take the following steps. Raise the solution container, readjust the flow rate, recalculate the duration of the infusion, immobilize the infusion site when necessary, and document your observations and actions. When your assessment indicates the flow rate is too fast, look first for the cause. If the solution container is higher than 3 feet from the site, lower it. If the tubing is disconnected, reconnect it, but first wipe the distal end with an alcohol sponge. Then tape the connection. If the patient has manipulated the equipment, tell him and his family not to touch anything. For the best control over the flow rate, use an infusion pump or controller, and remember to document your observations and actions. Infusion site complications may result from some type of trauma to the vessel wall during venipuncture, or infusion of fluids or irritating medications. For example, mechanical trauma may result when the cannula penetrates the vessel wall. Chemical trauma may result from irritating solutions or medications. Biological trauma may result from the introduction of contaminants.
Hello, Mr. Horner.
Hello.
I'm going to change the dressing on your IV.
How much longer do I have to have that in my arm?
A few more days. Is it bothering you?
Yeah, a little bit.
To check for infusion site complications, systematically assess the infusion site daily and during each dressing change. Remember to wear gloves whenever you touch the infusion site, manipulate the cannula, or change the tubing. In addition, palpate the site through the dressing at least once every 8 hours. Also, examine the site whenever you suspect complications. For example, if the patient complains of pain at the site, if the dressing is moist, or if the infusion becomes sluggish or stops. To begin your assessment, remove the tape securing the tubing. Stabilize the cannula and gently palpate along the course of the vein proximal to the puncture site. Assess for tenderness, swelling, or redness along the vein, a palpable venous cord, blanching, induration, or a change in skin temperature. Also ask the patient if he has pain or itching. Next, loosen the dressing over the infusion site, remove it, and dispose of it. Inspect the infusion site. If you see any redness, swelling, purulent discharge, or other unusual changes, suspect a complication. Next, compare the infusion site to the same area on the opposite arm. Look for any differences in appearance or contour. Infusion site complications that can occur include infiltration, extravasation, infection, and phlebitis. Infiltration occurs when solution leaks and accumulates in the tissues surrounding the infusion site, causing noticeable swelling. It may be caused by a displaced intravascular cannula or by an enlarged puncture wound. When you detect infiltration, discontinue the infusion, apply warm, moist heat to facilitate absorption, elevate the arm, restart the infusion at another site, and document your observations and actions. With extravasation, solution also leaks and accumulates in the tissue surrounding the infusion site, but this process may result in tissue necrosis. This complication, caused by vasoconstricting or vesicant drugs infiltrating the subcutaneous tissues, creates such serious problems as tissue sloughing. When you detect extravasation, stop the infusion and elevate the arm. Remove the cannula unless you'll need to administer an antidote. Apply ice packs or warm compresses for 20 minutes every 4 hours. And carefully document the location of the extravasation, its appearance, the solution and estimated amount infused, your nursing actions, the name of the doctor, and the time he was notified. Infection is another potential complication at the site of an intravenous infusion, and unless detected and treated promptly, it may lead to septicemia. Infection can be caused by both intrinsic and extrinsic factors. Examples include the patient's own skin flora and contaminated equipment. Faulty aseptic technique is also a cause, probably the most common one. When you detect infection, discontinue the infusion and obtain a culture of the drainage at the insertion site and the tip of the cannula. Then cleanse the site and apply bacteriostatic ointment. Wash your hands and put on new gloves. Restart the infusion in the opposite arm and document your observations and actions. Phlebitis is an inflammation of the vein wall. Phlebitis is caused by movement of the cannula within the vein or by the administration of such irritating medications as erythromycin lactobionate or vancomycin hydrochloride. In thrombophlebitis, a clot forms along the inflamed vein wall. However, thrombophlebitis may also be present without observable signs of inflammation. Although some degree of venous irritation can be expected with any intravenous infusion, phlebitis or thrombophlebitis is more likely to occur when irritating medications such as high doses of potassium chloride are being infused. Maintaining the same infusion site for more than 12 hours can contribute to the development of these complications. When you detect phlebitis or thrombophlebitis, discontinue the infusion and select another site, preferably on the opposite arm. Then, apply warm, moist heat to the irritated site. Later, you can use cold compresses. Be sure to notify the doctor and document your observations and actions. Systemic complications from an intravenous infusion are not as common as local complications, but they can have much more serious consequences.
Hello, Miss James. I have some medication for you.
Another shot. I feel like a pincushion.
I'm just going to put it right in here so it won't hurt.
Systemic complications may develop quickly and insidiously, and their signs and symptoms are less obvious and specific. Because of this, closely observe the patient immediately after starting an infusion or when any new IV medications or additives are administered. Check for systemic complications anytime you interact with a patient. Even subtle changes in the patient's appearance or behavior require further investigation. And carefully evaluate any complaints the patient may have. Many different systemic complications are associated with IV therapy, and all of them can be prevented. One group of systemic problems is associated with the side effects, interactions, and adverse reactions of drugs. The development of these problems depends on the drugs being administered, the dosages and routes of administration, and the status of the patient. If you suspect a problem, stop infusing the drug immediately. Change the solution and administration set, or discontinue the infusion. Notify the doctor and document your actions and observations. Septicemia is another systemic complication associated with IV therapy. It's caused by the introduction of bacteria or fungi into the administration set or solution container, usually at a connection. Suspect septicemia if the patient develops unexplained symptoms such as fever, chills, cold sweats, a drop in blood pressure, or nausea, vomiting, or diarrhea. Since this IV therapy complication is seldom seen, notify the doctor before discontinuing the IV and obtaining cultures from the insertion site, tubing, and solution container. Embolism is another type of systemic complication. It's caused by the inadvertent introduction of air or a foreign body, such as hair or a piece of IV catheter, into the venous circulation. Although an embolism rarely occurs during peripheral IV therapy, consider it a possibility if the patient's cardiac, respiratory, and neurologic status change drastically. Specific interventions depend on the type of embolus. However, stop the infusion, place the patient on her left side with her head lower than her heart, start oxygen, and notify the doctor as soon as possible. In review, there are many nursing responsibilities associated with the safe and effective implementation of IV therapy. Included are selecting the most appropriate equipment for treatment, selecting the correct intravascular cannula that's the best gauge and length, selecting the best infusion site, following aseptic technique throughout the patient's care, performing venipuncture skillfully, taking steps to prevent problems before they develop, recognizing problems when they do develop, and documenting your actions and the patient's response to IV therapy. A time-consuming treatment in any setting, intravenous therapy requires your finest skills to initiate successful venipuncture, to prevent potential problems and complications, and to intervene effectively when problems occur. Reviewing this program frequently will help you choose the appropriate vein or cannula for the patient, as well as the solution or medication. It will also help you detect problems early by assessing the patient skillfully and deal with those problems by intervening quickly and expertly.